Thank you for the kind invitation. Dottoressa Ghiotto apologizes, but she has just been called by the regional president due to an urgent meeting. So I'm going to substitute and take over. Vielen Dank zu den Kassenärztliche Bundesvereinigung für die kind invitation. It's a pleasure to share some of the experience due to the fact that Italy has been one of the first heavily affected country in the world and the first in the European Union. The first COVID cases were nearly simultaneously recorded in Lombardy and in Veneto. And in Veneto and exactly in Vo Euganeo was recorded the first death in Europe due to COVID. Only a brief overview about Veneto. We have nearly 5 million inhabitants that are nearly the 10% of Italy, and we are in northeast. Together with Lombardy, we are two of the major powerhouses of Italy. As you already know, the epidemic curve of Veneto is quite similar to the Italian one. Here we have the main events. We have the first cases recorded on the 21st February in Vo Euganeo, the death, and the first activation of the red zone in Vo Euganeo, together with the red zone in Lombardy, near Codogno. After that, after a while, a national lockdown was imposed on March the 8th, distinguishing the first phase of the pandemic, and then we have the economic activities reopening on the 18th of May. Right now, we are seeing a mild recrudescence of cases, and we are counting up to 27,000 positive cases in Veneto. What distinguished the response in Veneto to other regions were the low number of hospitalization that characterizes our system. And right now we have less than 200 cases hospitalized. A brief overview of the system. We know that is something different from the German health system. Is a single payer, tax-funded public health and social integrated care system, steered by 9 local health authorities with 26 districts in charge of the public health and ambulatory care function, 9 prevention departments, so quite a capillary system for the public health function, 68 hospitals, and nearly 18,000 hospital beds. What's very important, it's the number of the nursing home beds, more than 30,000. Due to the vulnerable population, it's quite a thing. The health system in Italy, as Professor Busse already said, as a regional structure, even if the national architecture is designing the system in 3 pillars, intertwined: the public health function, the hospital care, and the primary care, ambulatory care, that are under the same roof, the one of the local health authority. The health workforce in Veneto is composed of more than 10,000 medical doctors working both in hospitals and in outpatient clinics, but the main actors of the public healthcare response are the GPs and the community pediatricians, working with the role of gatekeepers of the whole system, both of the hospital and the ambulatory care. So our system was not unprepared, because we, since 2007, we had a regional pandemic preparedness plan updated in the next years. In 2009, we activated a regional center for disease control, a CCMR. And then after that, we had the Ebola preparedness plan in 2014. So in January, also before the declaration of public health emergencies of international concern, our task force and the scientific committee were activated, and the PPE and medical equipment to ensure that our health workforce was properly equipped were started already in January. At the local level, for each local health authority, we had an health emergency committee. Then after the first cases, we adopted many normative acts, starting from the public health plan, the critical care surge hospital plan, some measure for strengthening the response in primary care and for the health workforce, and especially in the phase one, the deferral of non-urgent ambulatory care. The main key components of what has kept our system sustainable during the COVID-19 pandemic, well, these concepts of our public health response. We had a massive, extensive testing strategy. After the whole lockdown, all the inhabitants of the village were tested, and the same measure were then repeated after 2 weeks. In all the local health authorities, we had a broad and extensive contact investigation and isolation. We privileged the home care for mild cases, treating at home and keeping so that the people could be kept out of the hospitals, and activating COVID hospitals only for acute cases. This can be seen by the high number of the swabs performed on the right side and the relatively low positive rate in the region. Also, the number of the people admitted to the hospital, the yellow and on the right angle down, is quite low in comparison to other regions. This was possible due to a strong primary care system and the activation of special and adoption of special measures. The first one was the activation of the special units for the continuity of care, the so-called USCAs, 1 per 50,000 inhabitants, composed by medical doctors and nurses, were in charge for suspect and confirmed cases. At the regional level, we extended their mandate for home care, caring in nursing homes, and having a surge capacity. They were active 12 hours a day, every day of the week from 8 to 20, and supported the primary care response in integration with the primary care physician, the GPs, and the community pediatrician. Then COVID-19 pandemic gave us the opportunity to boost the role of the Territorial Operations Center, the so-called COT, or the Continuity for Care Center, 1 per local health authority. So we have in Veneto 9 Territorial Operations Center in charge of the transitional care, to take care of people that should go to the nursing home or coming back home from hospitals, and their role is to identify any gap that is present between different level and coordinating care. During COVID-19 pandemic, the Territorial Operations Center played a pivotal role of integration of the public health, the primary care, and the hospital function. Through also the strong integration of the informative sentence, we activated a IT system for COVID-19 surveillance, contact tracing, and through the regional project of the electronic health record and the already available electronic prescription, we facilitated the care at home for our citizens. Telemedicine, even if with room for improvement, was a key component of the response, and according to also national norms, we made them equivalent to office-based visits in order to ensure the proper treatment and management of the patients. We, for the first time, introduced also the figure of the family nurse in charge for low complexity nursing in family and community settings, working closely with the GPs and the community pediatrician, both in local outpatient clinic, but directly at home. And then what we think that is a kind of very relevant component of our primary care system is an innovative model of integrated medical groups. That is a group composed by GPs and nurses, active 12 hours a week, in charge of the management for chronic and fragile patients in the whole region. As what can be seen as leitmotif of our response was the cross-pillar integration. The local health authorities in charge of both the three pillars, the hospital care, the public health function, and the primary care, through the territorial operations center and its integration role, where the components of keeping all the components aligned in order to align also the acute care beds response and ensuring the functional coordination between the district and prevention department, activating also an ad hoc operational team. During the previous presentation, were already acknowledged as critical issues the high workload, the training that was not always adequate of our workforce, the complex management of isolation, surveillance, the family and social condition, also together with the other stakeholders during the pandemic. The uncertainty and the constantly dynamic situation made the management of the epidemic quite complex, and also the deferral of all the activities now in phase 3 and 4 is a serious component for our hospital and ambulatory outpatient clinics. The main strength of our system was a prepared health system, so we were able to surge rapidly a response both for hospital, but we had already a community care level and laboratory capacity in place. The cross-pillar integration I've already mentioned. We had a good central management and communication with all the local health authorities and providers. The highly motivated workforce was another plus, and maybe you see in the news, but we had a frequent, consistent messaging of the community directly by the health and the authorities. Yeah, I think I made a summary of our system and how which components made the response one of in our perspective one of the most comprehensive. Thank you for your attention.